Okay. So the first thing I had on our agenda was like if we wanted a specific meeting day and time. And I don't know if that works for everybody with your schedule. Chris, I know you and I have been communicating and you have your daughter certain days. And of course, I don't know about your all's work schedule, but I can be very flexible. So, can we choose a specific day? Is there one that's better for everybody and time for these meetings?
I'm
Sure.
community based.
Oh, you go ahead.
Oh, I can do any time during the day. I set my own schedule pretty much, but I have my daughter Tuesdays, Thursdays, and Saturday nights. So uh, I actually prolonged her getting dropped off for this meeting so I can make this work. But Monday, Wednesdays, and Fridays are typically the best days for me.
Okay.
But I'll make it work either way.
Mhm. And I get off work at 6 p.m. Eastern Standard Time. So, they're pretty flexible where I work. I mean, if I'm on the adolescent unit, it's pretty relaxed. So I could always just kind of hop on a Zoom if I need to. But if I'm on the adult side, is the only thing is if I'm over there, it's a lot more busy. So I would probably have to meet after work, but I only work 3 days a week because I work 12-hour shifts. So I could definitely be very flexible with my schedule. Do you work the same days, Michaela?
I
I don't. That's the only thing that is the worst about working at a hospital is they just kind of have me all over the place, really. I work 5 weekend days a schedule, and the schedule goes out for about a couple of months. So Okay. I know pretty much in advance like what my schedule is though. But yeah, I don't work specific days. But Okay. For the most part, I have off on I will always work I pretty much work always Mondays and Tuesdays. Wednesdays and Thursdays and Fridays I'm off sometimes. But mainly Wednesdays and Thursdays is when I'm off a majority of the time. Okay, and then Aiden,
Um,
are you
I
our central time?
yeah. So
Okay,
I'm
go
just an
ahead.
hour ahead of you guys.
Yeah, go ahead.
But I can be pretty flexible. I pick up shifts during the week. I for sure work Saturdays and Sundays, but during the week I'm off unless I pick up a shift. So I can be flexible with whatever works for you guys.
Okay, and then Dantley.
Yeah, the student's last day was Friday, so I'm wide open until the remainder of this class anyway.
So what if we choose Wednesday? Because Michaela, that sounded like it'd be okay for you, and Chris, I think that's good for you. Can we do Wednesday? Um, and then I'm sorry, Michaela, with your schedule like during the day, or do we need evening time with it still on Wednesday?
So on it really so that's the only thing that sucks is I really don't ever really know what my days will be, but for a majority of the time that I look since I started back there, I've not really had to work many Wednesdays, but I get off at 6 p.m.
Okay.
Um
Can we do
but
like
like I said,
Wednesday at 7 Eastern time for everybody?
yeah, I think that works for me.
Hey,
Is that
works
good
for
for
me too.
everybody?
Yeah.
Okay, we'll just set that as like our standard um time because we're gonna have the group project and all of that. So
Right.
we'll just try on Wednesdays at 7 p.m. We'll try to set a schedule for that.
That sounds good with me.
Okay, perfect. So we'll jump into then I just put and Aiden, I know you made notes out here, and so please like I don't think I'm in charge of
No,
this
you're fine.
meeting in any way whatsoever. I just tried to lay it out because I do have the ADHD. I've got it. And so I have to
Okay.
like structure things for myself. So I had to make these headings. So
Oh, you're fine.
I was gonna start with the DSM. So the intro was from week 1, and I don't.
Aiden, you had kind of talked to him, so I don't know if we're supposed to do week 1 and week 2, but week 1 was on the intro of it, and then neurodevelopmental disorders. I think we're the first 2 from week 1. If we want to talk about that. And I I'll just open with this. I have not, because you all have been in the field and I have not, I haven't had a lot of experience with the DSM, so like reading in it was a bit overwhelming for me, to be honest with you. And I enjoyed it, but it was also a lot to take in, I think. So I'm interested in hearing from you all and your experience, like in the field and using the DSM for the intro and the neurodevelopmental disorder stuff. All right, and then I'll be quiet.
I just want to say, like, it's very hard to read because it's like a reference guide. It's not really like a book that's meant to be like read front to back.
Sure.
So it's more like, oh, let's flip to this part and figure out, if this meets the criteria. Or
Yeah.
usually, uh, the last class I had, we had to like figure out like the sections first. So before you even got into the diagnostic criteria, just try to figure out like the section. So then you would start there, and then after you got to the section narrowed down, then you would flip to whatever page. So you would never really like read it by like, oh, I'm going to go read
Straightforward.
about
Yeah.
neurodevelopmental disorders. So
Actually never used the DSM before because where I started out as a technician, so I'm basically just providing like patient care hands-on, and I'll do a lot of groups and things like that. So, but I do know that with the neurodevelopmental disorders that you definitely can get, like, if you're when you're in counseling or you're a therapist, it's kind of like a way for you to be able to look and see, like, if you're working with a patient who has ADHD or autism or something like that. It's kind of like a little way for you to see what their symptoms are and kind of match it to what it says on the DSM. It's basically what I've taken from it to kind of, if like you're getting ready to diagnose someone. But as far as using it in my current position, I have not yet.
Uh,
a lot of the developmental disorders fall into like the MMRD realm of things, like the autism and the developmental disorders. So I have several clients that kind of fall into those spectrum. So it was kind of like a nice refresher to like go through and like actual see the you see these labels all the time, and then you're not always sure like how people got them, and then you like to read through the actual diagnostic criteria. You're like, oh yeah, they have that and they have that, and.
Well, so I'm curious about your all's experience in that. Like, do people come to you already diagnosed, or do you?
Yeah, I mean, in my job as, like I said, the school counselor, yeah, the kids, we don't really diagnose in the school, so they'll have an IEP that already says that um, they're autistic or they've got ADHD from an outside diagnosis, and we have to make sure that affects their education in order for them to get the IEP. But yeah, it comes from outside, but kind of piggybacking on what Chris was saying, sometimes it helps to be an advocate for the kids, or because if they've got a kid with ASD, the teacher's meeting in their class that does these things, and it's like that, they have an abnormal social approach, or they do this, or they STEM, and you're like, yep, that's part of the diagnostic criteria. So they wouldn't have
Yeah.
autism if they didn't do those things. So let's try to, we're always going to try to bridge the gap or help those kids improve or improve socially. But it's like, yeah, they wouldn't have a label of ADHD if they didn't have some sort of, maladaptive behaviors, for lack of a better term. So just being like, yeah, that's part of it. So as opposed to it being defiant or non-compliant, it's like, yeah, sometimes that echolalia is just something that's inherent in their label.
So,
Mhm.
Dantley, do you never? I'm so sorry, Aiden, if you were getting ready to speak. So
No,
do you never diagnose them? Do you never send people
That's for
on, like,
license. Like when you're getting ready to do your internship, that's probably what they'll put you on is intakes and like diagnosing quite a bit because you'll get like a temporary licensure. At least that's the way Ohio works. Um, Dantley, I was school based for like 8 years, so I know all about like that process. I still work for the same employer. I just switched over to community based because the schools are getting a little much for me in my old age. But yeah, usually with the intakes, usually there's like a licensed professional counselor or a licensed social worker that will get a reference, and then they'll do the intake, and then they'll go through the DSM-5 and come up with like diagnostic criteria, and then they'll send you the information, and then like for me, I will develop the treatment plan, even though I didn't come up with the diagnosis, but this is even helpful for like going through the treatment plan. Like, even though they don't let us use the DSM-5 because we don't diagnose, you probably really should let the behavioral health workers have these so you can see like what diagnostic criteria they got that led them to that diagnosis. So then you could base your treatment plan around that. So you're just kind of shooting from the hip sometimes with these treatment plans. You're like, oh, he's got autism spectrum disorder, but if you don't really know what that entails, if it's just like a black and white thing, then you're making the treatment plan off of it. And then I guess it's probably not the golden thread as they speak. It's not going in tune with exactly what they're diagnosed with.
right?
Yeah. Yeah, with where I work, it basically what we do is we do an assessment, an intake assessment. So basically what that is it's just a series of questions that we ask them to see what's going on with them, what issues that they're having, if they're suicidal, homicidal, self-harming, anything like that, automatically meets criteria. And we do substance abuse too. But for the most part, when it comes to diagnosing, we have 2 psychiatrists that come to our units. They will diagnose people there if they've never been diagnosed, but a majority of them are already diagnosed. So none of our therapists, I don't believe any of our therapists diagnose. I believe it's just the psychiatrist, but I do think that they all kind of collaborate together in treatment team and kind of give all of their information, what they took from, their biopsychosocials and assessments and everything like that, kind of a combination, working with them individually in sessions and kind of helping assist with a diagnosis if they haven't already had one prior.
Aiden, were you going to add to that?
No,
Okay, I'm sorry. I thought we over talked you earlier. I
no,
apologize.
you're good.
And guys, I'm sorry. It was showing me that our time's about to run out, so I'm trying to upgrade so we don't have that.
You're fine.
Please forgive me here for one.
You're perfectly fine. No worries.
We might have to like stop this recording and reconvene. We might have to send her 2 recordings.
Well, it's charging me like a monthly thing, which
Oh, so we're costing you money right now?
no, it's fine. It's totally fine. I just need one moment.
I feel like I should like Venmo you half or something.
No. Okay. I told Chris the meeting now has unlimited minutes. Okay.
Yeah, I just got an alert.
I told Chris the other day, I'm like, I think we're all, if you go into counseling, you're just trying to figure yourself out. And I want you to know, I want to surprise you that I am a people pleaser. Believe it or not. No one could ever guess that.
Me too.
Okay.
Yeah.
I think I fixed it. I think we're good on our recording.
So should we read through like all the neurodevelopmental disorders through DSM-5 and kind of touch base on them?
Whatever y'all want to do. That's fine
Yeah,
with me.
I'm just trying to check all the boxes so that
No,
we
I'm
meet
open
all the
to
grading
whatever.
criteria.
We have a ton of things I think like, okay, so I printed out the syllabus to be sure. So it gave us prompts of things to use, and so here are a few prompts. The way I'm interpreting this is, or the most challenging thing is, or what does this look like? So if there are anything within that, I don't think we have to read through it. I think it's more like if there were any questions or anything like that that the reading brought up to us, then we should discuss it. Does that make sense?
Yeah.
Yeah.
Um, and I will say, like, the first DSM stuff, like the intro stuff, that didn't not bother me, but that didn't like give me a lot of questions. But this past one really did. And I've not had experience with the DSM as we talked earlier, but I made a note actually in my notebook here about, and I've been in my own personal therapy for a couple of years now about how codependency is not in the DSM. And that blew my mind because I'm like, okay, well, I'm a classic case of codependency, right? And I thought that was a diagnosis. And so just reading through the DSM in general and like learning what diagnoses are, was surprising to me. So I don't know. I'm again with the ADHD, I'm off track there, but
One thing I caught on to in our readings that I didn't realize is that it's the DSM-5 is labeled or like categorized by where the diagnosis would usually show up in a lifespan. So like developmental disorders would be like the
oh
easy,
yeah.
more predictable as a child, and then it goes into ADHD and autism, and like I didn't realize it was categorized by like lifespan, or they tried to do it by lifespan as the where things would show up in your life. Because schizophrenia usually comes in like the early
16,
19,
30.
20-year-olds, usually early onset, but not like in the teenage years. So, of course, that comes in second right after your developmental disorder or your, neurological disorder. So, I didn't realize that before.
Yeah, I think for me, like the whole DSM over the first and second week of things has been it's been an adjustment for me just trying to learn like searching up symptoms, right? So like we're reading these case studies and it's searching up the symptoms versus and Chris and I talked about like the case studies in part one. And I told him, I was like, it's mostly common sense, but then you think about it. And so in week two, I was just reading over some stuff today, and Maria from West Side Story, her case, and I'm like, oh, that's PTSD. Like that, my brain just was like, oh, well, that's PTSD. And it went to acute stress disorder because that's less than a month. And so like learning all those little nuances, I think, of it has been surprising to me of the DSM. That's been like one of the big learning things for me, I bet.
Yeah, and there's so much overlap, like you're saying, like codependency is not in there, but then I know like dependent personality disorder is, which is like a lot of similar characteristics of codependency. So it's like, and then yeah, it's like what makes it, the time frame can be a lot, or how many times a day. It's like pretty nuanced, honestly.
Mm-hmm. Yeah, absolutely. And go ahead. Sorry.
Oh, I had a course. It was similar to this one at the school I transferred from, and like we would go through and we would take a case study, and then we'd go through the signs and symptoms together as like in a Zoom meeting with the professor. So then we'd lay out this sheet. So then like the signs are like things you can observe like in the counseling session, like tapping foot and like all the things they're saying without saying, and then the symptoms are a lot of the stuff that like they're reporting, and then like we would break all that down and like write it all down on a sheet and then start trying to like gather diagnosis from that. So I'm kind of surprised this course doesn't like take you that route, because it really gives you a good like working understanding of like the DSM-5, like how that works.
Mm-hmm.
Like how you would do it from an intake perspective of, because you're coming in with a blank slate. Like they're just coming to you with a problem. They don't know their diagnosis. They just know like, hey, this is affecting my life. And then you're trying to like cipher through everything that they're telling you and try to come up with like the criteria.
Yeah.
And it changes. Like it's not like as soon as you get like black and white, like, major depressive disorder or whatnot, like that may not stay. Like 6 months later, you might not even meet the criteria for that diagnosis. Like, so it's like a working document.
I was gonna say that's definitely something that I noticed in the readings and the videos and stuff is, like in one of the videos she was talking about how she was she felt like she had PTSD, but she said she didn't have nightmares and like loud noises didn't really affect her. And I was like, I don't know if I would really consider that. I don't know if I would really consider that PTSD then. But that's just what I took from the video. But I thought that that was interesting because it kind of seemed like she did have some things that would categorize it as PTSD and then other things that didn't.
Mm-hmm.
So I thought that that was interesting to see and hear her talk about that because, a lot of the times I feel like people automatically think, oh, if you're in the military or if you were, in combat or anything like that, you're going to have PTSD. It's going to be associated with it. So it was interesting to see her perspective and talk about, what she went through and how it was different from other people.
I'm curious, are any of you all in your own personal like I'm in counseling myself personally. Anybody else?
I'm in this. The VA pays for my college through the rehabilitation counseling, so I'm
Okay.
I'm in this program from being in
From
counseling.
that. Anybody?
Yeah,
Amazing.
which is pretty beneficial considering they pay me to go to school and pay for the school. So I'm kind of digging
You
being
can't beat
counseled.
it.
You can't beat that.
No,
Not at all. That's awesome.
Anybody else in counseling personally?
Yeah, me too.
I'm not.
did a VA too.
Dantley, you're in VA too?
Yeah, yeah.
Okay.
are you chapter 31, Dantley?
No.
You should probably check into it.
Yeah, yeah, I'm gonna write that down. Yeah, for sure.
So
100%.
I think you only have to have like 10% disability or whatever to qualify. Yeah.
No kidding. That's crazy.
Yeah, I didn't even know about it. The counselor's like, "Hey, you ever thought about going back to school?" I'm like, "No."
Interesting. Michaela, you're not Aiden.
Not right now. I have been in the past, so
Okay.
Try to,
Go
it's
ahead.
actually kind of crazy that I haven't because, I'm going to school to be a therapist and I've had plenty of experience in it. And one of my best friends is an LCSW. So, you know what?
Okay.
I actually kind of use her a little bit as like whenever
Unofficial
best friend
Free
talk.
therapy.
Yeah, free therapy. Yeah, absolutely. That's what she does every day. She does like one-on-one sessions where she works. So I'll just text her and be like, hey. But no, as far as like an actual like meeting with a therapist and or weekly or
You don't.
whenever it is, the length of time, I've never done that. I've actually thought about doing
Never?
it. No, never ever. I never
Oh my
have. I've
God.
thought about doing it though, trying it and seeing if it would be beneficial, which obviously I think it would be.
Oh, you should do that. Because again, I've never done this from your all's standpoint of being on the other side of it. So I look at it from my own, like as a patient. And when I read through things, I'm like, oh my God, like there are things I don't share with my counselor because I'm afraid I'll be labeled a certain way, right? So
Yeah.
like she'll ask and I'm like, "Oh, it's not that bad. It's not that bad." Because I don't want it to be like, "Oh, well you've got, major depressive disorder." I'm like, "Oh, no, I don't have a disorder." Like, "Oh, it's not that bad. Nothing's that bad." But it's been very interesting reading through these things and like I put myself in that position again because because I do have a counselor that I'm maybe not fully honest with in that way, but that's how I'm reading through everything. But, and I don't mean to skip us along, but I am going to move on to, um, our learning activity one.
I had
So,
one more point on the
oh yeah, no,
DSM-5.
please do.
It's kind of a group discussion. Like
Yeah.
one of my major struggles, because we'll get to where we're like trying to come up with diagnosis on ourselves, like the
Mhm.
mild, moderate, severe, and profound, like trying to figure out which, like autism, you can meet the diagnosis, but I have like nonverbal autism kids, and then I have like highly functioning, like
Very
trying to figure out the
right.
mild, moderate, severe, and profound. And they don't really give a lot of clear guidelines as far as like which meet, like you really kind of feel like you're shooting from the hip when you're kind of coming up with those. So if anybody has a better strategy, like if you've ever read through that and like trying to figure out how to figure out which is which, like please share.
For sure. Okay, and I don't want to take time away from that. I'm gonna move on to our learning activity one, but please, like, we can go back to that. And I hope, like, I sent the email out to everybody. We are our own little, I'm sorry, I used my hands a lot, our own little, like, counseling group with each other. So, like, feel free to bounce ideas off of each other. But so learning activity one with Edward Cullen. Um, and so I put in here like the notes that I put in here are just this is how I
Gonna have to move
jot
my
things that
computer elsewhere because
oh no, you're fine. This is
the
how I
dog's barking
jot
all around
things
me.
down. This is how I jot things down so I can work through stuff. But so the learning activity one, we are looking for client behaviors, thoughts, and
Hey, mate.
physiological
Hush.
symptoms. Go ahead. Oh, sorry, Michaela, was that?
I think she's herding dogs.
I'm
Oh,
talking to
okay.
my dog.
Herding cats, I think so. Um, but anyway, client behaviors, thoughts, moods, and physiological symptoms. If anybody wants to start us out.
And
Talking about
that,
the. Sorry, you go ahead,
go ahead.
Aiden.
Edward
Um,
Cullen is
yeah,
what,
Edward
yeah.
Palmer.
Hmm.
The rest of that question was to suggest a diagnosis of persistent depressive disorder.
Yes.
Um, so she originally diagnosed him with major depressive disorder. And then towards the bottom, it talked about like other suggested diagnoses. Um, I just pointed out that she she chose not to go with the persistent depressive disorder because he hadn't reported at least 2 years of symptoms prior to the first major depressive disorder he had or major depressive episode he had. So that's just something that I pointed out as to why they didn't go the persistent depressive disorder route. But that was a little confusing to me with it saying he doesn't report at least 2 years of symptoms prior to the first major depressive episode. The wording's just a little weird to me.
I was just going to read through the diagnostic criteria for persistent depressive disorder. Depressed mood for most of the day for more than not, as indicated by either subjective account or observation by others for at least 2 years. So that's what you're talking about, like.
Yeah. Which that's why I was confused, because it said they chose not to go that route because he didn't report at least 2 years of symptoms before the first major depressive episode. But I didn't
They
see
went with
like,
major depressive disorder.
yeah, but I didn't see like in the DSM-5 where it talked about there having to be at least 2 years of symptoms before that first episode. So I was kind of struggling with like some inconsistency between like the DSM and the textbook. I don't know if it was just their wording or what, but
Yeah, I don't know. I mean, like right in A, it says for at least 2 years. So I guess maybe because he didn't report it for 2 or more years.
That is one thing I struggle with a lot. And I've, and again, I put myself in that position because I've not been on the professional side of things, but I don't report things a lot, right? So, like, what happens if it's been longer than that, but they're just now coming to you, kind of thing? And it's self-reported. So I don't know. That's one of my struggles.
Like I was saying about like it's kind of a moving target.
I feel like maybe
I don't think it's
persistent.
a perfect science. I think as long as you can get like the symptoms and like what's bothering, then you
Yeah.
can kind of like narrow it down and get like a working direction, and you're going to get more information, and you might have to adjust and be like you might have started out with major depressive disorder, and then you're like, oh wow, this has been going on for 4 years. Like you might get more information and have to adjust,
Yeah.
like Aiden's talking about.
I feel like based on what I've read, that the PDD is basically a little bit less severe than MDD. So maybe like she switched it after she noticed some improvement. Is that possible? Because that's something that I was wondering. Like, could they switch the diagnosis if they've noticed like something changed?
Oh yeah, I think that's I think clinicians. I mean, I think they adjust it all the time.
Yeah.
That's my experience. Like it seems like it's, and also typically like almost all social workers and counselors like will always have a supervisor. So you're rarely ever making these diagnoses by yourself. Like
Right.
it's usually like a team effort.
Mm-hmm. Yep. And you got to meet with your supervisors all
Yeah.
the time and have the the little meetings with them. So I actually used to work at Brightview, and we used to have to do that all the time. So anytime we discussed anything about any patient, our director and our clinical director and our supervisor always knew exactly what we were doing. So that was a good point that you made, because I think that that's important.
And then some of them switch from adolescence to like adulthood because like
Hmm.
adolescence can't be, what is it, antisocial disorder or whatever. Like, I don't even think that's an adolescent diagnosis, or at least it wasn't in DSM-4. So it's like something unruly, or I forget what it is as an adolescent. But then once you become an adult, the diagnosis can kind of switch, but it meets like the same criteria.
And then I would say too, if they're that closely aligned in the DSM-5, I mean, I would think that the treatment and planning would probably be similar too. You know what I mean? Whether you're doing
Yeah, that's
severe or moderate, well, we're going to do CBT and some psychotherapy. You know, we're going to do,
yeah.
here's our plan to treat it. If it's that closely aligned, the treatment probably wouldn't be that much different, I would imagine.
It's true.
And you're probably going to do a referral for pharmacology if they meet any criteria for a diagnosis, and then let the psychologist make, or the doctor make some kind of recommendation, because that's out of our scope of practice. But then it is in our scope of practice to like refer. So
Right.
the moment they kind of meet the criteria, then you kind of got to make that referral and push that along. So.
We
I
have
don't want to rush us, but I don't know if our time's going to end at 8 because I did 7 to 8. So I'm going to move on to any medical or environmental factors identified with Edward. And
Well, he can't die. That's a problem.
he's immortal, so there's that. Or he believes he's immortal.
Yeah.
Delusional at
He
best.
also gets suicidal at one point.
He's really obsessive with Bella. I feel like that's one
Yeah.
of the biggest things I saw was
Obsessive,
the
for
dependency
sure.
upon Bella.
For sure.
He's really stuck on her, saying, "Oh, I'm doing this for her. This is all for her." But
That's
really,
all
he
for
should be doing
her.
it for himself.
Mhm.
Yeah.
And there was also the environmental or social stressor of the discord with neighborhood
I
members.
put that in here
So
too,
the
yes.
werewolves.
Yeah.
Well, imagine being a senior in high school for like 50 years straight. I mean, that has to be stressful.
At like a century,
Awful.
yeah, of it.
How many problems Edward Cullen had. I used to I watched that whenever I was younger, and I just didn't really pay attention to it. But when I was reading that, I was like, "Wow,
You're
I never
thinking about
realized
it
any of
totally
this."
different now.
Yeah, I'm like,
Yeah.
man, he was struggling.
He disappears for Bella for like 3 months. And
Tried
then he
to
tries to
commit
Um,
like commit
suicide.
suicide by the, what is the Valetari or whatever?
Yeah.
Going to
I
expose
need to
himself.
rewatch
And
it.
It's like rewatching it now after that. I don't know about that. I
I
never
would
watched the
honestly
full thing, but
rewatch it to
to
get a good
diagnose.
laugh.
now you're going to diagnose like every
That
movie you
that
ever
too.
watch.
Okay, I'm gonna move on to learning activity 1.3. So Miss I don't know. Seeley, am I saying her name right? Seeley?
We'll go with
Um,
it. Sounds good.
we'll go with it. Goals for treatment. And again, I'm going by my notes here. Um,
She's from the Color Purple movie, correct? Is that what this one is?
yes, that's correct.
I haven't watched that movie since I was like 10, I think.
10.
Oh, hot minute.
Um, yeah, so I think what I wrote was to help understand the gender and racial and socioeconomical conditions that gave rise to the maltreatment and then relieve symptoms of PTSD. That was the goals for treatment that I recorded. And that it was behavioral and that she does have freedom to make her own choices. I don't know if anybody's got other to add to that.
So, what is the exact objective on this? I didn't read over it.
Well,
So,
there's
we're trying to come up with a treatment
goals
plan
for
for her.
goals for treatment for each concern. Well, and I'm paraphrasing. And are they behaviorally identified? And then modes of treatment and methods of intervention.
So, her diagnosis is PTSD.
I didn't record that, but I think so. Yeah, symptoms of PTSD. That I put that in my notes. So I think that. Yeah. Can
So, I
you
would think
hear
goals
this
would be like
background
something
noise? So I
small,
need
like,
to. I'm so sorry.
what is it?
Can you all hear my background noise?
I can't hear anything.
Okay, perfect. I'm so sorry. Continue.
So, goals would be like small, measurable objectives. So, like, trying to think if I was like writing the treatment plan, what a goal might be for PTSD.
It's interesting for me with her, because and it's so all of these cases are a little bit weird pop culture because in like in the story, it's not okay for her to feel a certain way, right? And so for me, like I wrote down here, like helping her to understand that she can make free choices, that she's not tied to this story that's been her past or whatever. And again, pop culture stuff. Um,
How would you make that a measurable goal? Like, how would you know if
how
she
do
would
you
like
make that
obtain that?
and that's the question for me too, is like how do you make that measurable? And I think about it with myself and like my own background, and it's like to allow myself to make my own choices. How do you make that a measurable goal? And I think it's just like,
Well, usually, I think you do like small measurable, like the treatment plan would probably be like be able to process 2 times weekly, be able to process like 2 times weekly when you made decisions on your own, and didn't allow your trauma to make decisions for you, like
for
stuff like
you.
that.
Okay.
And you would make it like pretty small, like you wouldn't want to be like, you know,
And so for me, from the other side of it, I think of when and how can I trust myself? And again, and to your point, like in small measures, like, can I trust myself to do X, Y, Z? Okay.
what do you mean by trust yourself?
Well, and so I've lived through some traumatic stuff, and it's like, can I trust myself to make a good decision here, in this small, like contained,
Yeah. So
right?
I think like a goal for that would be like if she was having a similar issue, would be like, okay, what's the first level of trust for me? Like, what's the first thing that I do that demonstrates trust? And then that would be like my first goal. Like, okay, I will share 2 honest, I don't know, life events with my counselor
Yeah.
per session or something
Yeah.
like that.
Well, and I think that's their point of what they're trying to get to this of like, she's been so beaten down that like, what can you trust, right? And it's an extremely small scale of trusting people around you. Who can I even share these little
Yeah.
small moments of life
Or you
with?
could have like a goal of like talk to 1 stranger per week, or I mean, just anything. Like have
Yeah,
one social interaction with a stranger per week. Like,
sure.
yeah. But then you also have to have like your counselor interventions because you can't just give them a goal and then you're not going to do anything. So then,
Sure.
as we're going to get into in this class later.
Sure. You guys have stuff to add to that?
Yeah, I like what Chris has said, just like building slowly, even like recognizing the places you don't trust yourself might even
Yeah.
be part of it, like um, recognizing symptoms of, internal systems when you start to feel that like you're going to make a bad decision or whatever it is, like replacement behaviors instead of making the poor choices you're discussing. I mean, yeah, I think it's gradual, then like things like DBT or whatever to expose you to it to be able to go there. But like I said, it's right, lack of a better term, baby steps. You wouldn't want to be like, go there and don't do it before it's like, what are the places, what are the symptoms, what are the triggers, what might lead you to this, and then so it's more of a slow rolling out process.
And this is kind of hard to come up with because usually in a professional setting, especially now with client centered
Yeah,
like
exactly.
counseling, like the client always comes up with the goal. Like you as the clinician rarely are like, hey, this is your goal, because then they have no ownership in it. Like the clients always develop the goal, and then you kind of come, like if you're putting together a treatment plan, like, okay, what do we want to accomplish? Like the client's always the one that tells you what they want to accomplish, because otherwise you're putting like your own bias onto it. Like, hey, you need to work on this, which is not your place to say as a clinician or as a mental health professional. Like it's always up to them, like what they want to work on, regardless of the diagnosis. Like they could be schizophrenic, whatever. If their goal is not to take their meds, then that's not your business to say like, hey, you should have a goal to take your
Right.
meds. Like,
Right. I definitely think starting with that would be a good thing to add, would be like her doing positive affirmations to kind of remind herself that, she's worthy of love and respect. Kind of talking to herself in a positive way to help her feel like, she deserves to be happy, and that she's able to create a new life for herself and kind of start over.
Yeah.
And not let her past kind of follow her.
Hmm.
And that has a lot of research data to it too. I mean, you're always going to hear like
The
you know,
positive affirmations. Yeah, I feel like that's
well,
like
I mean,
a
everything they want
go-to.
now to be like, I, I don't know why the term's escaping me, but like basically like uh, things that are proven to work, basically.
Yeah.
So that's definitely something that
I
has
feel
a
like
lot
I
of
use
research
positive
behind.
affirmations myself. I
Yeah,
I was
definitely feel
gonna
like it's
ask
like a
that. I was gonna ask if you all do the things that like you
evidence based.
said.
That's what I'm talking. That's what I don't
Yeah,
know why, but
like
everything nowadays needs like
based or
almost all your interventions have to be some kind of evidence based, or insurance is not going to pay for it.
Mhm. Okay, so that's part of, and I think it came in the psychopharmacology thing, but like the insurance stuff of it. So are we recommending things to people because of insurance or is it because of what's good for them? And this is going off topic completely, but um I don't know. And
yeah.
again, I'm not in that space that you all are in. I'm on
I
the other.
definitely feel like that can become an issue when you're working in an inpatient facility for sure. Like for an inpatient facility and an outpatient facility, from what I've
You
witnessed,
got to code it
yes.
a specific way. Sure.
Hmm.
Yeah.
yeah, and I do a second job as a BCBA, and we have to write insurance authorizations. And so, yeah, a lot of times it's just that it's like, I mean, not to tell tales out of school, but it's like, what you write in the insurance authorization may not be exactly what the treatment, you just have to word
Sure.
it, get it
To get
approved by
it covered.
insurance, and then you can, like I said, you're not doing anything unethical, of course, but you're just like, okay,
Sure.
they want it. If you say a functional behavior training, though, they want to know what that look. We can't say that. You have to use these words. So it's like, okay, it's the same thing, but just the wording has to be. So
Sure.
learning that like second language of talking insurance to get it approved is, can be a thing too.
For sure. Yeah.
I have like a half caseload of like teens, like expelled teens, and then my other half is elderly. So I think what I run into, especially with the elderly clientele, is like sometimes they're grasping for straws to get them a diagnosis because the only way we bill is through Medicaid. But like
Mhm.
they might just need help going to get out once a week to get groceries and that thing, kind of thing. Is that intervention like helpful for their mental health? Yes. But does the diagnosis actually warrant like
Line up.
what we
Yeah.
put on to like what we send to Medicaid and say, hey, they got depressive disorder, they need to get out of the house once a week? Like sometimes I think they kind of grasp at straws to get a diagnosis because that's you got to have a billing code.
Right.
That's
To have a reason. Yeah.
Yeah,
I
and
think when, oh, go ahead, Aiden. I'm
you're
sorry.
good. At the facility I work at, there's just like more questionable things. So that's another difficult thing I've been dealing with recently is like um whenever you notice like unethical things going on, like them grasping for straws to admit someone um that like probably didn't need to be admitted inpatient because, it's a private facility and it's mainly money based, it seems like. But
trying to fill a bed. Is that what you're
yeah,
saying?
yeah. If the census is low, they're wanting to admit.
Hmm.
Uh, yeah.
Yeah, we've had a lot of issues with that too, especially with the inpatient facilities. When you're working with psychiatric patients, you're gonna have a lot of people that are coming in with pretty severe disorders and conditions, and it can get pretty dangerous sometimes whenever they admit people that don't meet criteria, because that happens a lot. They will admit patients that do not meet the criteria that our doctors ask of, just specifically to get that Medicaid. And it's just kind of like, I feel like that's kind of where it kind of comes in, when it's like the people that are the most worried about that aren't the people that are working with the patients hands-on every day. So I definitely think that that is a big, big, big issue that I've noticed in the past 5 years that I've worked in mental health. Um, and it's the same way in outpatient at the substance abuse places. I worked at the detox facilities. So the same way. People could be improving, people could be coming in there and have been there for years and they're still doing the same thing, the same motions, counseling, case management, even when they don't need it, they'll still make them go to it. So it's definitely an issue for sure.
So if we hit on all of our talking points,
I think we
I
have not everybody was prepared for chapter 2. Um and I don't know on the syllabus if we were or were not supposed to go to chapter 2. Aiden, you said you messaged and they said no on that.
I kept getting kind of like different responses.
I know
Like the first
it's a
message,
mess.
they were just like just learning activity 2, but then the second one said learning activity 2, so I don't know.
Have y'all looked at chapter 2?
listened to it today, most of it.
Anybody
Quite a
else?
bit today.
A little bit.
Yeah.
Um,
It kind of goes into like a lot of like what you're talking about, like the
DSM stuff.
codependency and like what's diagnosable, what isn't
yeah,
diagnosable.
that today it brought it up for me. I was like, oh my God, like I can
Starts walking you through
remember
how to use the DSM-5 a little
how to
bit.
use it. Yeah. This is a lot of too much personal information, but when I was married, I asked my ex-husband to go to marriage counseling. And so and I didn't know my undergrad's in psychology, but I didn't have all of this awareness. And so I asked him to go to marriage counseling. And so we go, and she said, "Have you ever heard of codependency?" And I said, "Nope." And she was like, "Go look it up." And so I went home and I'm researching codependency. And the next week, my ex-husband said, "Well, you're the one with the problem, so you should probably go." And he did not go to marriage counseling with me. That's neither here nor there. But I thought codependency was a diagnosis. I thought she had diagnosed I thought she diagnosed me years ago with codependency because I was like, "Oh yeah, I hit all of these triggers, you know." So anyway, learning about it, I was like, "Oh my God," knowing that it's not an actual diagnosis for one thing.
Mhm.
Um, and then learning more about like the stuff around it, I guess, has been very eye-opening for me. So, I don't know if it's meant to go in this first video, but if y'all want to talk about any of it, if you've read about it or any of that, we can talk about it.
Like read about codependency. I'm trying to.
Oh, well, not just codependent, like from our second week of things. If y'all have read about any of that and y'all want to talk about it, we can. Codependency stuck out to me because clearly I lived through that diagnosis. I am codependent. It's fine. I'm Denise.
I think one of the things that kind of stuck out to me from the week 2, kind of as we're talking about, like I mentioned earlier, like the moving target. where they talk about a lot about like what is a normal response, like because you lose your job, does that necessarily mean you're depressed, or are you having a normal response to like losing your job, or do you actually meet a diagnosis? I think it brings up like a lot of questions of like, I think, I don't know if everybody talks about it, but like the realms I've worked in is like it seems like you always come back to the medium, like you come back to the middle. Like sometimes you get highs and sometimes you get lows. Typically, people will come back to the median. It's like, are they on the high? Are they in the low? Like, are they in the valley? Are they in the peak? Like, it's all cyclic, but like where are they at in it? Is it really like a diagnosable thing, or is this just like an expected, like, hey, my mom died? Like, am I having a normal like
Episode.
response
Yeah.
to that, or is this going into the abnormal to where I need to like psychological intervention or pharmacological intervention?
So I think that's a good point, Chris. Like, so part of the DSM thing and the TR where it got updated, um, the updates were for grieving, and then I have to go back to my notes on what it was. It was grieving, and there were a couple of other things, but like
Yeah, like
long term.
grieving has 7 stages, I think, but then they like don't go in any kind of corresponding order, and like you can experience them either which way. So then, like,
Yeah.
okay, grieving is a natural human process. Is that like something we need to give this person a diagnosis for? Like, are they depressed, or are they just going through like?
And I think it goes like if it's for and so my mom did die last year. And Chris, you and I have talked about this, but like
Mhm.
my mom did die last year, and then her mom died. And they were the two most prominent people in my life, right? And so here I am. April 26th of this year was 1 year since my mom died. And then her mom died November 4th. And it's like the prolonged effect of it, right? And so, and I go back to like, I think about how am I doing as a patient, but um, it's how long has that happened? And then I think about me as a patient and I say, well, I'm not totally honest about how much it affects my life. But how long has this grieving happened? How long has the effects from it happened? And I think that's the big thing with regard to that. With regard to the update of the DSM of this grieving, I can't even remember, and I'm looking back at my notes, the specific title of it, but like the grieving effect of it when it goes beyond X amount of time. Um, and I'm on this side of it of like, it doesn't feel abnormal. It's been a year. It doesn't feel abnormal. I don't think I've changed things in my life for this grieving or anything like that. But at the same time, I don't think you get over it. Certain deaths that you have in your life within a year. So I don't know. Anyway, I'm sorry. I got off topic again. ADHD brain.
I think you bring up a good point. Like, how can you put in black and white what's normal, what's a normal response, and what isn't a normal response? Like, how do you even begin to
Yeah.
classify? Like, show me
Mhm.
the normal person. Like, I want to meet
Right.
them because I've never
Right.
met one.
Agreed.
So I
Yeah,
don't.
because I feel like everybody kind of deals with grief in many different ways. Like, for example, we have patients that will come in that have dealt with like one of my patients that I had, he had lost his wife to cancer and he was in psychosis because of his grieving. He was
Sure.
grieving so much all at once. It just kind of all just hit him and it put him into psychosis. Um So I definitely feel like it just, knowing the effects of the grieving is really important because it can determine like knowing and understanding what is going on and why they're going through what they're going through, whether it's psychosis, having PTSD, anxiety, whatever it is. Um, and I definitely think that is beneficial too whenever I'm able to talk to them about it and kind of give them a little bit of assistance during that time because I'm sure that having to go to an inpatient facility and then dealing with that all at the same time is can probably make it seem a little worse sometimes because I feel like a lot of them say, I feel ashamed to be here, or I don't really like to talk about my problems. I don't really like to discuss it. It's hard to open up and talk about that. But I definitely feel like it's so important to know the effects, especially when it comes to what they're, you know, what type of issue that they're facing.
I think you bring up a good point. But it's also like, I think it's individual responses too, because like your trauma might not be my trauma. And then you got
Right.
to look like, what are they doing to cope? Like, do they have good coping responses? Like, I was in Iraq. Like, I would be side by side with somebody in the same firefight, and then they melt down and get sent home. And I'm like, okay, fine by it, but I might get hit by it later. Like, but then, like, okay, how are you coping with your trauma? Are you like drinking and boozing every night, or are you going home and doing yoga and sitting in the sauna? Like, how are you dealing with like what happened to you? Like, there's so
Right.
many factors that come into it, but like we focus a lot on like what's your coping strategies, what's your coping skills, how are you dealing with it, and how something affects you. We could be side by side, and how you took it and how I took it could be completely different because we have a different worldview coming into the situation.
Yeah,
Yeah,
agreed.
Aiden, I'd like to, if I can, pick on you a little bit, just because you had put notes in here and I don't see them now, so I want to make sure that your voice gets heard.
oh, you're good. I had just the only note I had added was the criteria for the persistent depressive disorder, which we talked about earlier. Um, but yeah, I was looking at chapter 2 and some things that we had kind of touched base on that it talked about was stigmatization with labeling, which we kind of talked about a little bit earlier. Um, and then I thought it was interesting the potential for diagnostic bias. Um, so, and that was discussing like clinicians who might overdiagnose, underdiagnose, or misdiagnose clients of specific demographic groups based on ethnicity, gender, age, or socioeconomic status. Um, so I thought that was interesting. And then it did talk about how in the DSM, each diagnosis includes like information about like
The
the
cultural,
culture
yeah.
related issues and gender related issues, which is good.
I loved that part of it. And actually, like, I made notes about it because, and again, and I've talked about it, I'm very open about me needing therapy. I need it and I love it and I enjoy it. But I don't think I'm as honest as I should be because I don't want to appear weak. You know what I mean? So, um, like even in my grief, like losing my mom and losing, I'm like, no, I'm good. And like, I try to ask my therapist, I'm like, how are you doing? I text her all the time. I'm like, how are things for you? Like I'm, um, so I don't want to appear weak and I don't like it is very, um, I grew up with a father who told me, who still tells me, you're very sensitive. I'm like, no, well, I am. Yes, I'm emotional. Um, and so it makes me not want to be. And so, like, even at my mother's funeral, I didn't cry, like things like that. Um, and so, yeah, to go back to like how you present yourself to your therapist, they can only help you with as honest as you are to them, right? Like, so they can only, you guys can only assess and help with whatever you're presented with. And so if I come to you and I'm like, oh no, things are fine. I get sad sometimes, versus um who I really am inside. You can only do so much with that. So I go back to that. And I have thought about that through all of these questionings. It's like, how am I presenting myself? and and the bias of it all and the stigma of it. So being labeled depressed, being labeled anxious, like all of the I don't like that. I don't like that at all. And so when I go like to my primary physician, I'm like, oh no, things are fine. And I go to my therapist, I'm like, oh, things are fine. I'm just a normal amount of depressed. But at the same time, I'm living with these things. I don't know where I'm going. So
I
I
don't want to be your
I
clinician, but I have 2 points,
I
one off of
know,
yours
right?
and one off
I'm
of
like,
Aiden.
ooh, I got all these points.
please.
So imagine
Everyone's
trying
like,
to
let me
diagnose
diagnose you.
Edward Cullen and you only watch like 10 minutes of Twilight. That'd be pretty hard to do. So like, and us digging into the DSM-5, like imagine trying to diagnose somebody and you got like 40% of the information. Like, so if you're really there for change, I think the biggest catapult for change would be vulnerability. And off of what Aiden said about the overdiagnosis, and I'm sure Dantley sees this, like we talk about like what's the normal thing for behavior for like grieving. Like I see boys overdiagnosed with ADHD all the time. Like what is being a normal 7-year-old boy? Like you're expecting this kid who for the last 10,000 years has been a hunter-gatherer tribe running all over hunting and climbing trees and like does he look like he has ADHD when he's on recess or does he look like he has ADHD when you're asking him to sit still and pay attention to a topic that doesn't interest them?
Interesting.
Like, so I think there's a lot of biases that go on. And there's also, I've seen it, Dantley's seen it, I'm sure, where the teachers will push the diagnosis like, hey, because teachers just want to get through their day. So they're like, hey, I got this one
Jesus
little
God, will
problem
you
child.
please
Like,
medicate
he
this
needs an
child?
IEP. He needs diagnosed with ADHD. You see teachers, oh, he's got ADHD, make them diagnose it all the time, which is completely out of their scope of practice. But it's like, hey, I'm 30 years old into my tenure, and little Jimmy will not sit still, and all the other kids do. And it's like,
Medicate him, God.
yeah, like, well, let's stick him on some meds, get him an IEP, get him an intervention specialist to pull him out, get him a Chris or a Dantley that'll pull him out and take him to the gym, get some of this energy out. Like, because I'm not dealing with him, I have 25 other kids to teach. So I've seen overdiagnosis come in the school system a lot. And it's usually biased and it's usually a lot of times it will be African American kids. Like if you get a hyper African American kid and a white teacher for whatever reason, because they usually aren't really one thing, like African American households tend to be like really loud. Like if you've like been in that environment. And so like loud, rowdy, like this kind of thing, like that's a normal thing for the kid. So they expect it in a classroom, and then the teacher's just like, oh, I can't handle this kid. He's loud and he's obnoxious and he's everywhere. And it's like, have you been to his house? Have you like seen like how they talk to you? Like, this is like probably quiet is abnormal for him. Like he probably thinks this is like he should just be on Mars. That you're asking him to sit at this desk and just nobody talks, nobody's yelling, nobody like I always say, like if they don't have the chaos, they're going to create it. Like they're used to chaos. So if they don't have it, they're going to make it. So I used to tell teachers that all the time. But yeah,
So true.
I think I see overdiagnosis in schools quite a bit. And I don't really know what is ADHD. Like, I really wish we had a different. My undergrad's in education, so I wish we had a different like teaching system. Like, what is a normal response to an 8-year-old boy to school?
Yeah, that's a we say that a lot too. Of like, is it ADHD or is this a future blue collar worker? You know,
Yeah,
guy like, or they're lazy or they're unmotivated. Then I'm like, all right, guys, come help me carry in this stuff and figure out how to stack it. And they're all like running to go do it, and they're carrying
yeah,
boxes and boxes and boxes. And that same teacher or teacher will be like, like Chris is so lazy, and it's like, no, he's just not motivated to do. He likes tactile stuff. He wants to work with his hands. He wants to dig in the dirt and play. And like you said, he doesn't want to copy your PowerPoint and they give him a label, and it's like, no, this kid is just, and I do like what Chris was saying and Aiden too, with the cultural thing. It's hard, blind spots are blind spots for a reason. You just think, oh, I'm going to look through my lens of what's normal behavior or and so, yeah, it's hard for teachers. And I imagine as us as clinicians to be like, we only have our own viewpoint, so that it's important to take those cultural considerations into account when listening to people's behaviors or what we might consider maladaptive. We're like, no, that's what my culture does. I mean, I'm like I said, Eastern Kentucky. There's a lot of we're Appalachian, Wolf County, very small, and there's a lot of traditions and cultures that we have that if you share them with the masses, they're like, oh yeah, that's not that's not the way to be, and more confrontation or saying things a certain way, and it's just like, oh, that's our culture. It's not maladaptive where I come from, but if I look at it through the lens of someone from Chicago, that might seem like a wild way to do things. So I think that's important too, just sussing out the cultural differences in everybody.
Well,
I agree
so
with
I
that.
love, I'm sorry, I don't mean to interrupt. I love my kids, I've put in Montessori, and I don't know if you all are familiar with it, but like my undergrad, I started elementary ed, and then I became a TA, and I was like, yeah, absolutely not. I don't want to do that. But I learned about Montessori along the way, and so I put my kids in Montessori, and it's very much the ownership of your education, of your being, of your like it's just ownership of everything. And so like I even joked about my ex-husband, we don't co-parent well, but I told him this last week, we do week on, week off. And this last week I said, I gave them a checkout list, right? So I was like, it's a checkout from mom's hotel. Here's what you got to do before you can check out from mom's hotel. And they're so used to with Montessori checking the boxes. Like I did this, and this. That my daughter got the biggest, she's 12 years old, the biggest smile on her face. And she was like, okay, I can check these boxes. You know what I mean? And so to your point, Dantley, about like schooling now and like how do we measure things like that? And so for me, like my children literally measure it by, did I hit these? Did I mark these things off? So, and I'm getting ready to homeschool my daughter. My son's got 3 more years in Montessori, but my daughter, I'm getting ready to homeschool her at 7th grade. But it's very much the marks of, all right, I set my day up for this. Did I do that? And I do the same thing, and you all might too. I'm like, on my day, I'm like, I got to do this, and this. Did I hit those? Like, would check mark on, and I carry them over. I'm not really great at check marking everything, but it's like I need to get these things done, and so my daughter's coming out of school learning these things, but this is not what our public schools are doing. So to your point though, Danley, and for counseling purposes of like, and I see it for myself of like, okay, I I am depressed like chronically. And so did I shower today? Check. I did that. You know what I mean? Like just checking the boxes. Like, yep. So to your point, what can we give to people? The check boxes of things that we can give to people.
But I think like I don't know if you've like put all this together, but like that's how you make a treatment plan. Like you're talking about like, did I shower today? So like if you're working with a chronically depressed person, like a goal would be like, are you showering every day? Like maybe that could be like a goal for you. Maybe that could be something you need to put a check mark by. Yeah. So like when you like, you can spin this all back to yourself because you have an excellent reference point in that you're in counseling and you kind of know how it works. But think about the goals that you're making for yourself. And then if you run into somebody with like a similar diagnosis, or maybe you can relate it to them. I mean, you don't want to like, you never really want to give your personal information out to a client, but like you can spin it in a way and like, I knew somebody and they struggled with this. They wasn't even, it's hard for them to take a shower every day. So maybe that could be something that we work on, like just baby steps to like start making you feel better about life is the grounds for a treatment plan, like, which is where this class will go eventually. But I'm sure I have to write treatment plans every day. I have like 25 overdue treatment plans right now that I should probably be working on.
I don't miss doing treatment plans. I used to do them at Brightview. I do not do them at my current position, but I know I will eventually have to again, but it's fine. But I definitely, yeah, they are. They're helpful though for the patients. I definitely feel like they actually really like to discuss them, and it
Can I
helps them kind of
say,
stay organized.
as a person on this side of it, I've never received a treatment plan. And so when I read about them, I'm like, wait a minute, I was never involved in this treatment plan. Like, so I'd like to ask you all, have you involved your clients in your treatment plan?
I think it's KCRET almost mandatory that you do.
Yeah, you have to, because you have to ask them
Well, I've
questions.
never been involved ever.
Yeah, wow, that's
I
shocking
can
to me
1,000% guarantee you have one if they're charging your insurance, because that's the first thing your insurance
I'm a
will look at.
self-pay, honey. I'm a self-pay.
What is it?
I'm a self-pay. It's
Oh, okay.
You should still be doing your treatment plans even with self-pay, because
Yeah.
that's a part of your treatment process. Like if you're, that's what helps you stay, organized with your measurable goals and to see if you're improving. And
I've never and never in
it's
my life
beneficial
have
for
I
both you
received it.
and the therapist, so they should definitely be including you.
I've had a couple of therapists. Never in my life have I ever received a treatment plan. Ever. Not never. And now
Wow.
I'm on medication, honey. I'm on anti-anxiety. I'm on antidepressant. I'm on Vyvanse. Never have I received a plan of any sort.
Hmm.
Hmm. I know.
I mean, maybe they might, like, is it just kind of like where you meet up with them and it's like a one-to-one and they like take notes and maybe they just use
It's
their
one to
notes?
one. It is one to one, but
And sometimes, like at the VA, I don't necessarily like go over it, but they might kind of do it like kind of coolly, like, hey, what about the goal of like
I'm not a veteran.
you get enrolled in UK, like you get enrolled in grad school like this month. Like you get enrolled in your classes. That sounds like a good goal. And I'll be like, oh yeah, that sounds like a good goal. Like sometimes they do it like that, and then they'll be like, hey, sign here. Like you never actually see the plan, but you kind of see like what they're doing or how they're building it.
Right there.
Now mine's like, can you Venmo me? And will you make sure that you put this on the Venmo?
No. What'd you say, Dantley?
I was just saying that's the way my therapist always, like it's not like let's sit down and go over like step 1, 2, but it's like, hey, for next week, let's think about, during the week,
Yeah.
How can we avoid these triggers or do this? And then usually that's how we start. Like, okay, so last week I talked about this. How did that go with
Yeah.
triggers? So it's like I said, I feel like he's doing it, but it's like he's a more coolly, thinly veiled as opposed to let's sit down and look at 1, 2, 3 with a
Yeah,
graph.
it's not like, hey,
Maybe
sit
they're
down and
not
read this
saying,
document and
this
tell
is
me
your
what you
treatment
think about
plan.
this treatment plan. It's not always that.
So a client, like, most clients aren't going to really know like what a treatment plan is per se. So if they're just kind of going in and saying, hey, let's make sure we're following our goals and we're working on our coping skills and things like that. It's just kind of like maybe they're just considering that just part of the session. They don't really think of it as a treatment plan, but the therapist knows. But
I don't know. Maybe I know too much. I don't know. No one knows.
I feel sorry for the TA that has to watch this recording. That's who I feel bad.
Well, we're gonna end this recording. Do you all have anything
we've definitely
Did
surpassed
we hit
the
all
35
the
minutes.
talking points? I want all my points for this hour of my life.
I better get 12 points.
Yeah, no kidding.
11 to 85.
You say that, Michaela?
Yeah.
Okay.
I want 11.